So I think we should stick to the time and start our session. It's basically a 2 minutes video session. It's a competitive session. And the aim here is to give some message to the audience. There should be some tip which they can take with them. With that, we are going to have this 2 minutes to win session. Your marks will be given here. That will be based on subject's originality, 25 marks, presentation and quality, 25 marks, then the punctuality, that means you have to finish in 2 minutes. Your video should finish in 2 minutes. And the relevance and conclusion. Based on these, the marks will be given. And there is an award for the best. And if possible, we'll do the second best and runner-up also. Can you hear the volume? So our first presenter is Dr. Harshad Sare. Dr. Harshad, please. He is going to speak on vitreous lavage in upright position and innovative topical air fluid exchange for recurrent VH.
Hello everyone. I'll be presenting an exciting and innovative approach in ophthalmic surgery, an upright vitreous lavage, an innovative topical air fluid exchange. I have no financial interest. Coming to background, a 38-year-old gentleman presented with diminution of vision in right eye post pars plana vitrectomy with air tamponade secondary to vitreous hemorrhage associated with type 1 proliferative diabetic retinopathy. After observation for 1 month, he was posted in OT for vitreous lavage, but in innovative way. Procedure involved. A single 5 ml syringe with 30 G needle is injected at 6 o'clock position under topical anesthesia under strict aseptic precaution. Gradually, air is injected inside the globe and allow the vitreous fluid to come outside simultaneously on the same syringe. Here's how it works. Improved gravity. Assistance. Blood, debris, and fluid are naturally directed downwards due to gravity, improving clearance and minimizing turbulence in the vitreous cavity, also enhanced visualization by reducing pooling of blood. Globe pressure is checked throughout the procedure. A 3.5 ml vitreous fluid is aspirated from globe, and while same amount of air is replaced by it. Take-home message, an upright vitreous lavage. Topical air fluid exchange for vitreous hemorrhage represents a promising innovation in ophthalmic surgery. It offers better visualization and recovery without going for re-vitrectomy. Thank you.
Thank you, everyone.
So you're pushing air inside and the fluid is coming by gravity?
Yes, sir. We are maintaining the globe environment by pushing the air inside so that the pressure inside the eye increases, and with that pressure, whatever the residual fluid is there, it's coming out from the same syringe.
It means you have to withdraw a needle a bit, because if you are pushing the air, then you have to, withdraw so that the vitreous can come easily.
Not, sir. We just need to push the air. The eyeball pressure will increase, and simultaneously it will automatically. I don't need to withdraw it. It will come automatically in the same syringe without withdrawing.
So air can also come out, huh?
Yes, sir. Only air.
It was a post-vitrectomy eye?
Yes, ma'am. Post-vitrectomy. So post-vitrectomy, like 35% people will have re-bleed. So in order, to avoid the second surgery, I just need, this is the OPD procedure we do, and we are just avoiding the second surgery, and the visual outcome is also better, ma'am.
What about the safety of sepsis in
Ma'am,
OPD?
that procedure I do in, mostly I have done in OT only with the
No,
all
you
the
have done, but
Yeah.
do the guidelines permit you to do any procedure which is intraocular in OPD?
No, till now I haven't.
Then ethics come a $1 million question in this, right?
No, ma'am.
Innovation is fine, but the place is,
Ma'am, that I have done in our OT, not in
OT, he's
OPD.
treated
huh,
in the
OT is fine, but you said OPD.
No,
You said,
No, he didn't. He didn't.
okay, then it's all right.
Yeah.
One more
How
thing.
do you monitor the IOP? Because how much air are you injecting?
Ma'am, simultaneously I was just checking with my hand only and then pressing little bit. If I think it is more, then automatically the whatever the fluid is, it is comes out. Then I will go in hypotonus. Then again I will inject and the fluid will come.
Any risk of injury to the lens? Because
Yeah,
this was
there is a
phakic.
risk, ma'am. Till now I have done 4 in phakic and total I have done 12. In that 4 till now I didn't have anything, but yeah, there is a risk benefit ratio is still there.
So have you checked the arterial status after the procedure?
Yes, sir. Post surgery, I will just check the periphery as well as the disc pulsation.
See, the eye, always the fluid goes down. So where do you position your needle?
And it will be in the 6 o'clock like this. I will just push, it will come automatically like this.
It's in a sitting position. You're keeping face upright.
Yeah, upright. Patient will be sitting in upright position. That's why the name upright vitreous lavage. I'll ask the patient to sit and I will go and like.
Despite that, there will be some fluid below that needle height, isn't it?
At the time of last, while removing the needle, I will just gradually remove that needle and whatever the like residual, it will come. Yeah, 10% chance is there that residual fluid will be there, but yeah.
My one suggestion is that you can mark the needle also, so that how much you are in, you can at least
Yeah.
assess it from the outside.
Sure, sir. Next time I'll apply for it. Yeah.
You're using 30 gauge or 26 gauge?
Ma'am, 30 gauge.
And how much is the needle into the vitreous cavity?
Ma'am, it's goes like almost. Initially, I start with very like half of the needle. Later on, while pushing, it goes sometimes 75 to 80%. But while removing, mostly 75 to 80%, the needle will be inside that.
Isn't there a chance of making a break in the retina?
Ma'am, what, ma'am?
Break in the retina in that case, 75% needle size is quite a bit. And
Ma'am, but it will be through the pars plana and yeah, but I will.
better titration of the
Yeah.
IOP and the globe size
Yes.
probably would make it better.
Yeah, ma'am.
Safer.
But a thick vitreous hemorrhage will not come out from a
No, ma'am,
30
it is a
gauge.
post-vitrectomized eye.
Vitrectomized rebleed. Fresh rebleeds, is
Yes,
it? You
yes.
don't allow it to get organized.
Yes. Generally we wait, but if it is not result, then I'll go and then inject.
Thank you.
That's
Thank
a
you
good,
very much.
good.
Thank you,
It's
sir.
an
Innovation.
innovative thing, yeah.
Thank you, sir. Thank you so much.
Dr. Rohit is here. So we'll not give a mark on this. But since it was selected, we have to just give a presentation. No marks please for this. Basically, it's a CRAO. So distal massage, acetolamide, then paracentesis. So CRA closed, opened, but on the periphery we have got a blockage. I mean to say, आसमान से गिरे खजूर पे अटके.
No, he's not come. No mercy here, sir.
Anyway, we move on to the next, Dr. Harshvardhan Patil. So, Dr. Harshvardhan will be speaking on Harsha Nag, a new chopper in the town.
Hi everyone, presenting to all Harsha Nag chopper. An ideal chopper should pierce the nucleus and give a good amount of lateral pressure. The various choppers which are available in the market, among the bouquet, most commonly used are the Nagara chopper, the sharp inner cutting edge and the blunt tip. And some of us have been using a long, sharp chance chopper. So let's see what are the problems with these choppers. Nagara chopper, in the initial stages of your career, if you are not confident enough to go to the equator, it doesn't crack the posterior plate of the nucleus. So if the posterior plate of the nucleus is not cracked, the whole nucleus comes under the gap. So there are more chances of doing an anterior failure. By using a chance chopper, the tip is blunt and it can give nucleus drop like this. So I have decided to modify a long diagonal chance chopper just by bending 0.3 to 0.4 mm of the blade to the left side. So by doing this, the sharpness of the chopper is maintained. This is how it looks under the microscope, whereas because of the lateral bend, it gives a good amount of lateral bend. So let's see in a grade 4 cataract. See how easily it cracks the nucleus. A little bit harder cataract. After piercing the probe, see how easily it pierces the nucleus and there is a good amount of lateral traction. So the posterior plate of the nucleus is easily. Rotate the nucleus, pierce the probe, repeat the procedure 180 degrees apart on the posterior plates. See how easily it gives a good amount of lateral action and cracks or chops the nucleus. I am doing a direct chop here. So I chop the nucleus into 4 pieces. Because the tip is blunt, the resistance for damage to the posterior rotation of the nucleus is very easy. Yes, the lateral bend gives a good amount of lateral action. This is in grade 5 nucleus. See how easily it pierces the nucleus and see the amount of lateral action. So just by a simple modification of cast lighter, lesser grades of cataract, it is like a butter knife passing through the. See how easily it cracks. Thank you.
So no patency, no legal issues. Anybody can bend and use the chopper. Thank you.
Basically, you turned it on the which side?
Left side.
Left side.
Yeah, I'm a right-handed surgeon, so I'll be chopping with my left hand.
Okay.
So for a good amount of lateral traction and piercing the hard nucleus easily, the sharpness is maintained and the bend gives the good amount of traction to separate the hard cataracts, fibers of the hard cataract, especially in leathery cataract.
So how does this bend helps bending the things?
Bending mainly gives us, because of the hard cataract, the bend goes and sticks into the hardness of the nucleus. So just by easily we can pull the nucleus apart. So the posterior plate is cracked in cases of leathery cataracts. The main intention is to crack the posterior plate, so in hard cataracts.
But when you are piercing it, if it has a straight tip, then
Yeah.
pierces easily.
You
but
are
with
not
the
bending
bend,
it more than 90 degrees, madam. It's bent just 30 to 40 degrees, so the piercing is not affected.
So maybe when you are piercing it, you have to do it at an angle and then make it straight.
Yeah, it's a diagonal chopper with a sharp cutting edge and a sharp tip. So just 30 degrees bend will pierce the nucleus. It doesn't affect. If it was more than 90 degrees, definitely it would have affected the bend, piercing.
Even when our choppers bend a little bit, actually we find it difficult to chop actually. But here you are deliberately.
No, sir. It's been working very well because of the sharpness of the long 2.5 millimeter modified Chang's chopper with the inner cutting edge also. Okay. The tip has to be maintained, and because of the bend, because of the handling of the assistants also, even if it falls and all, the tip is sharpness is maintained
Lost.
in this.
Okay, here it's maintained.
Maintained, sir.
Dr. Harsha, in my opinion, I think keeping one sharp tip is sufficient, and if you can modify our technique, then we just hold it firmly and then we can even split with the Sinsky hook. There is no need to put another sharp thing, and it's like a nag. You are keeping a one cobra inside the eye, because we need to go underneath the rhexis, and for a moment you are not visualizing the tip, where the tip is going. So sometime it can create, but in your hand it works.
Here we will not go to the equator, sir. You can diagonally pierce it, just before the rhexis margin.
That's why I asked, if you hold it firmly, and you keep the hold firmly, and then you can split even with the
Yeah, you can do it even with the Sinski, you can experience that. But the bend gives a good amount of lateral track. The force required to separate it laterally is reduced because of the bend. That's the main intention of bending it.
Yeah, so it means we can also tilt a Sinski also, so that we can get the advantage of that.
The piercing will be a little difficult. Yes. In our part of the country, we have two sickles for gardening. One is a straight sickle and one is a bent sickle. The straight sickle is for just growing, whereas the bent is to remove the mud around the trees. So the removing the mud or the piercing the substance is easier in this case.
Thank you.
Thank you.
Dr. Parth Palan is here. He's not here, but he's given a very good video. I think we shouldn't give marks on it. No marks. Yeah, use of now iris clip claw lens is big, and coming a big way. It's much easier than doing a SFIUL. Of course, everything has its advantage or disadvantages.
Leading to ovalization of the pupil with consequent correctopia. Here, the inflammation is non-standardized and requires relevant surgical skills. To overcome the mentioned challenges, we demonstrate an alternative technique of iris claw implantation, which uses a needle as a guiding wire for perfect centration. This is a case of IOL calcification, which needed explantation. Corneal incision is widened to accommodate the IOL which is being explanted. Thorough anterior vitrectomy is being performed to avoid any vit restriction during placement of the iris claw lens. Air bubble is injected, following which pilocarpine is injected to constrict the pupil, helping to form a uniform round pupil. Anterior vitrectomy is repeated. We wait for the pupil to constrict. A long 10 or proline straight needle is placed in the cornea. The lens is held in the center of the optic with the lens holding forceps and inserted in the anterior chamber to the corneal incision. With the needle being a guide to centration of the IOL, it is carefully implanted in the retropupillary plane. Nasal claw is enclovated in the mid-iris or the 2/3 1/3 junction of iris tissue, since it is relatively thin, avascular and non-dilating part of the iris, followed by the temporal claw. Viscoelastic is injected and the needle is removed. Sutures are placed to seal the corneal wound. Viscoelastic wash is carried out and the side ports are hydrated. Peripheral iridectomy is made in order to prevent pupillary block. The needle serves as a guiding wire for perfect centration and helps do away with the need for a second instrument. The advantages of this technique include that it uses only a single instrument, which makes the surgery very easy. The instrument acts as a third hand and an anterior chamber maintainer as well. Perfect centration can be achieved with this technique. We decided to name it the NAIL technique, which stands for Needle Assisted Iris Claw Lens Implantation.
So the voice was probably a bit compressed in 2 minutes, so it was looking a little funny. But I think it's a good technique. Let us see whether it touches cornea or not. We are not very sure. So we move on to the next talk by Dr. Jashri Barot. Again, it's on IOL scaffold. Safety gears for explanting IOL.
Safety gears are very important when we are planning any adventure activity. So the same surprise came to me when I got a post-op refractive error of +3 diopters. The other eye of the patient was 6/6, unaided, and so you can play the music, please. And so I had no other option but to explant the IOL. Now, saying is easier than doing it. So you have to remember that you have to be careful about not disturbing the wound, the incision, your cornea, and the posterior capsule. So here, my second IOL, which I am introducing now, after just tilting and lifting out the first IOL out of the bag, this IOL has now acts as a safety scaffold. My PC is now far away, and so there is no chances of injuring the PC. So then I can comfortably go on and cut my IOL into 2 segments and without disturbing the wound. We should enlarge the wound a little bit so that the integrity is maintained and take out the pieces one by one. By this technique, what happens, we protect the cornea, we protect the wound, and we also protect the posterior capsule. And everything has been done very smoothly, as we can see here. So definitely this safety gear was indeed helpful. Thank you so much.
So basically it's protecting your cornea or the posterior capsule?
The posterior capsule, because when I am cutting it, there is still the chances that I may rip the posterior capsule at some point or the other. So it's better to take the precaution, because posteriorly I have saved my posterior capsule, and also that when I'm cutting it, I am confident that I'm not disturbing the wound or the cornea also as well. But yes, my take-home message is that slightly we should enlarge the incision size so that we don't create a ragged incision at the end of the procedure.
With 2 IOLs in the eye, your AC will automatically become a bit shallow. So how is your cornea protected? Cornea is actually now a little more unsafe than before.
No, we had used liberal use of viscoelastics is very important. So in these cases.
I don't know, with that, actually the IOL comes out so easily.
No, ma'am. It will come out easily, I think, because this across of IOLs, they are a little bit bulky. When we try to, it's easy to inject, but when we take it out, we need to enlarge the incision size. So instead of enlarging it to such an extent, cutting it into 2 bits, I felt that
that's
the
fair
size.
enough. But that comes in the AC to cut easily. Like, I didn't know you really need to have that thing so much.
It is for
yeah.
So you mean it's providing additional safety?
No,
Pardon, sir?
It's providing additional
I do
safety?
this regularly.
Visual safety, yeah.
See, the advantage of the IOL scaffold, what Jayashree just now
Sir,
told.
Dr. Mohan, please. Sir, aap baad mein.
Oh, sorry.
You are a completer now.
Huh?
You are a completer. No comments from your side.
That doesn't matter.
No, sir. Baad mein.
Okay, fine.
Thank you. Thank you so much.
Thank you, sir. Thank you.
So our next speaker is Dr. Mohan Rajan. He's going to present the magic of cotton bud.
I have some water before that.
Hey, don't tell me. There is positive water and confidence.
They've given us this. We are supposed to fill and
So it's okay?
1 minute. Before that, I would like to compliment Vinod. Let's give a big round of applause to Vinod for this wonderful session. I've been participating for more than 5-6 years. I won 3 times. Last year also, I gave it to the younger fellow.
Now you are emeritus.
Yeah, no problem. But I just want to, because I'm participating, just to give you one simple message. That's the idea of this 2-minute tip, 2-minute video. One simple message which you can do it tomorrow. So let's start the video now. So this is, when you're doing phaco, when you're having a PCR, when you withdraw, what is happening? There is a forward movement of the PC and the opening of the PC. If you have a toric lens, when you withdraw, see what's happening. The toric lens rotates, okay, from the axis, from the intended axis. Again, when you have a patient with IFIS, you can see how the iris is coming out. Okay, all these problems can occur when you withdraw the instrument from the eye. You can see how the PC is moving forward and chamber is becoming very shallow. So these are all the problems which you see. You can see again a patient. I can see here how the pupil is becoming small, and once you withdraw abruptly the instrument, either the phaco handpiece or the IA handpiece from the eye. So what I have devised is a very simple thing which you can do this. Okay, this is called the cotton bud, the magic of the cotton bud. You can see how this patient has got IFIS, the iris is coming out when you withdraw. You just take the cotton bud, okay? See what I'm doing now. When you come out of the eye, just press that, okay? Very simple, okay? Everybody can do it. Even you press, you see, there is not a micron of movement of the PC. The pupil stays still, and then you can go ahead with the rest of your procedure. And this patient again has got IFIS. You can see here the previous one. You can see this patient, the iris is not coming out at all because you are holding that. Again, a patient with a toric lens, the lens does not tilt at all because you are holding that lens, the incision very tight. This is a magic of the cotton bud. I'm sure everybody will be able to do it without any problem, and you can do it on a routine basis. For all patients, you can do this to prevent the posterior capsule coming forward, the iris from coming out, or the lens from rotating. Thank you very much.
Mohan, this is a wonderful video. The idea is absolutely amazing.
Yeah.
The only negative thing about the whole thing is that you're using a cotton bud, which is a vegetable material. So you devise a metallic system to press the wound and not the cotton. That is my suggestion. Besides that, everything is wonderful.
No, are you not using cotton buds at all?
I am not. No.
How many of you are not using cotton buds?
We are using.
Everybody is using.
And for him, name it Vexile sponge.
The idea is...
Sponge is, the problem is sponge you cannot press, madam.
Sorry.
That's a problem.
The idea is not to promote something which is not
I know,
advisable.
I got your point, but I'm asking.
If 100% of the people are using formalin in the OT, it is a carcinogenic agent and should not be used. So that doesn't deter Indians from not using it, unfortunately. But that's
No,
that should not be the
reason why I asked.
Let us not argue on that.
No, I'm not arguing. Please, the reason why I asked, because I thought everybody is using cotton buds.
We are using.
That's all.
Sir, it's a good suggestion, but because now we are using 2.2 millimeter of incidence, clear corneal incision, so now the things has become quite simple, because even if we withdraw suddenly, the chances of sudden collapse are quite less. But obviously, it's a suggestion is always good, because even with the polar cataracts and other things, we are doing the same things. We are keeping second hand ready with viscoelastics, we fill it.
His eyes are very good, especially low resource settings when you don't really have too much of stuff with you. So cotton bud is good, and even 2.8 Pro one can easily use. 2.2 needs a little better phaco system also. The lower end phaco systems don't come with the 2.2. So yours is really good thing. I think it's a very helpful.
No, I think whether it's 2.8 or 2.2, when you come out of the eye, there is going to be a forward movement. Please understand.
There is.
Doesn't matter whether the size of the incision. So what I'm trying to do is just keep the cotton bud, seal that incision before you come out. That's all.
It's a good tip.
Very good concept, sir. Yeah.
Thank you.
But you can always put in viscoelastic from the side port or fluid also at the end of the surgery. You can use
viscoelastic, you require an assistant to put it sometimes.
No,
it is a little more cumbersome. So that's why I'm telling you. This is a very simple tip, straightforward.
I think cotton bud helps sealing in the incision.
You don't have to stop the irrigation. If you want, you can stop the irrigation. Yes.
Even if you are not hydrating the wound, just press it with the any sort of, even the marocell or the cotton bud. It basically serves the purpose. Even when you close it, when you finalize your surgery.
I think it's a very simple, very easy to use and very practical tip. Thank you so much.
Thank you very much.
Thank you, sir. Dr. Rohit is here. He was busy in another session. So his number is number 2. He's going to present something is better than nothing. So at least he come.
This is a case of a CRA. So the patient is 67-year-old male with hypertension and ischemic heart disease, came with sudden diminution of vision since 2 hours, and best corrected visual acuity was counting finger close to face. So this is the fundus photograph of the patient. If you see closely, there is a plaque in the central retinal artery, which is being focused here. And this is the OCT of the patient. So ocular massage was given to the patient, and patient was asked to breathe in the bag. And then patient was taken into the OT for AC paracentesis. And also acetazolamide tablet were given. So after AC paracentesis, the patient's pressure was reduced, and we were hoping that there will be some visual improvement. So some amount of AC fluid was withdrawn, and post-op day 1, the next day when patient came, the vision was good, but patient was seeing a scotoma. So when we saw the photo, the plaque cleared from the central retinal artery, as you can see here. And you can see the plaque is moved to the periphery in the inferior temporal quadrant, where you can see the pale retina. But there was a BRAO which has settled in. You see superiorly, there is a BRAO and there is pale retina over there. So patient was having an inferior scotoma, but patient's vision was 618. So at least something he gained. Thank you.
So, I just was discussing, it was like Asman se gire khajur pet ke.
It depends on the patient's availability. If patient comes fast, then we can do anything. We can just do the paracentesis or massage or something. But if the patient comes late, that we can't do anything. Even these things won't work.
Within few hours it helps actually. Yeah. If it's more than a day, it doesn't help.
This patient came within 2 hours, so maybe that's why.
That was a huge advantage actually.
Yes. Thank you.
Thank you very much. Dr. Satish Shet, he is going to present the CTP, cut, trim, paste, no suture glue, free novel conjunctival autograft technique for primary pterygium.
Respected judges and friends, pterygium has been an enigma for most of the surgeons because of the recurrences that we are encountering. So this is a disease of subconjunctival tissue. So why discard the entire pterygium along with the subconjunctival tissue? So we devised a novel technique where we harvested the superficial conjunctiva overlying the pterygium and excising the subconjunctival tissue. So when superficial conjunctiva is harvested, it is harvested from the limbus back about 2 to 3 millimeters into the temporal or nasal area. So since we don't have to use a commercially available fibrin glue, we are puncturing the small epithelial vessels there to generate the autologous fibrin. So the harvested conjunctival graft is again reposited there. So the pterygium part over the limbus onto the cornea is excised, and this conjunctiva is well positioned. So in the cases of double-headed pterygium, where there is significant loss of tissue, this can be an added advantage. So once the conjunctiva is secured well, it has got excellent cosmesis and hardly any recurrences so far. Thank you.
Good idea. What about that slight retraction of the?
No, that can happen when the size of the autograft, we usually keep a size of about 25 cubic millimeter size. Sometimes there can be a slight displacement, but which can be again reset back on its. It depends on the amount of fibrin glue. Because we are not using commercial fibrin glue, there can be a slight displacement.
So what was the incidence of displacement of grafts? Because in some of them they do displace actually substantially.
Yeah, hardly less than 5%. Now in our institutes,
this is all right. 5%.
Yeah, all the postgraduates are performing this surgery now.
But do you put any contact lens on top? No suture, no glue,
no
nothing.
Contact lens, no contact
but
lens.
Hasn't the tissue histopathologically changed because of being on the pterygium, the conjunctiva?
Histopathological study, no, when we are suspecting any malignancy, we are not advocating this technique. But when it is a pterygium per se, then there is no issue at all.
A little relaxation in the conjunctiva from behind really helps. It brings the conjunctiva forward, so that really works.
It's basically the barrier effect.
Yeah, but otherwise, like the discrepancy of the size also is taken care of. If you release the conjunctiva, a little bit and pull it like that with the Johnson bud. Again, Mohan's Johnson bud. So pull it this side.
Yes, ma'am.
The discrepancy is taken care of by the conjunctiva coming from the fornix, the inferior and superior.
Yeah, we encountered few cases of conjunctival granulomas, which was again excised. So the cosmesis was still excellent.
For how long you keep the dressing? 24 hours or what?
No, sir, we don't do any dressing at all.
No
we put a patch for about 4 hours.
Okay.
At the end of 4 hours, we look at the graft. Once the graft is intact, nothing has moved.
Why do you need a patch now that
now we have, now this is a
lens.
scleral contact lens has been developed by Dr. Kakadia. So, but still, we have been carrying out this procedure for long. So, pterygium costs, the pterygo costs about 1,500 rupees per scleral contact lens.
So you're taking the graft from the same area of the pterygium?
Yeah, it is a superficial overlying
Normally
conjunctiva.
one takes the graft from the superior conjunctiva and then places the graft over there. We've been using autologous, the blood itself acts. That's not a new idea. It's been used around, but you're taking the graft from the same area. So is it not leading to a gape? Because you're excising conjunctiva and placing it forward, but the rest of the part, especially near the muscle, there would be a gap of the conjunctiva.
Only the conjunctiva from the limbus onto the cornea, only that part is excised. So remaining conjunctiva is kept as it is. So why we are cutting it from all directions is that there should not be any conjunctival retraction.
No, what madam said was there will be same thing what I asked, slight retraction, but you said that is okay, it's not recurring,
that's okay.
Causing any cosmos. So that's what he said.
We have not had any recurrences so far.
So no fibers from pterygium or anything coming is sticking to it?
Sir?
No cells or fibers coming from the pterygium?
No, nothing has happened.
Okay.
So maybe you need a little longer follow-up. What is the longest follow-up?
We have got a follow-up of 5 years now.
So there is what is the incidence of recurrence of pterygium?
Yeah, but in this particular technique, we had a graft loss of about 4 or 5 cases, and those cases were done by our postgraduate residents. So when we have performed the surgery, the graft loss was also 0. We haven't had any graft loss. So in cases of double-headed pterygium, where there is lot of
in those cases definitely
and normal tissue. So here the superficial conjunctiva is normal. It is a disease of the subconjunctival tissue, whereas we have been excising the pterygium and the subconjunctival tissue as a whole.
But when you are dissecting it, if there are buttonholes in the superficial conjunctiva,
that
it's a very thin.
Meticulous dissection is quite important. Yeah.
Why not keep the conjunctiva, which is not the limbus side, fornicial, still attached? Just go underneath, remove the pterygium, come out.
And this aspect I wanted to highlight because that will have a retraction from one end. So we wanted to keep it a free conjunctival graft in all directions.
I'm still surprised that it is not moved.
It
4
doesn't.
hours of patching and it's done.
Yeah. 4 hours of patching. We don't even keep it for 24 hours.
Very nice.
Thank you.
Thank you so much. Now the next presenter is Dr. Ojas K. Bhanot. He's going to present simple sterilization, the UV laser.
Bacteria, viruses, and fungi all can cause ocular surface infections. When such a patient puts his head on a slit lamp, these pathogens can be transferred to the chin rest and headrest, indicating a dire need for disinfection. The process of disinfection is time-consuming, difficult in a busy OPD, and is labor-intensive. Let's take a look at the regular cleaning process in the OPD. This process seems very inefficient and cumbersome. So what's the solution? We have a solution, and it's called UV laser. Here is a 3D model for the same. The body of the UV laser is made of a polycarbonate shell and the base is made of a foam rubber composite. The doctor's side is curved and the patient's side is flat. The foam rubber composite helps to reduce the impact of the docking process. The inside of the shell is completely covered with a reflective material and has 3 UV LEDs. The UV rays from these LEDs bounce all around the reflective surface, ensuring complete sterilization. The UV laser moves up and down on a slider attached to the side of the slit lamp. The doctor rotates the UV laser into position, then he slowly docks it onto the slit lamp, which automatically turns on the UV.
Can a CTR be placed? Just it might be some problem there.
Bacteria, viruses, and fungi all down on a slider attached to the side of the slit lamp. The doctor rotates the UV laser into position, then he slowly docks it onto the slit lamp, which automatically turns on the UV lights. The base here has been removed for demonstration purposes. The doctor then lifts up the UV laser and puts it back into the primary position so that it doesn't hinder his vision. This is a very cheap solution to our daily sterilization needs, costing approximately only 800 rupees and requires only a 10-second holding time.
How do you calibrate this 10 second?
Sir, there's a formula for the dose is equal to irradiance into time. So time is equal to UV dose upon irradiance. So we have to have the capacity of the UVC light, the distance from the target, and intensity. Say we can calculate the time, sir.
So it's a only calculation. Have you sent the cultures or other things?
Sir, it's a prototype right now. It's the first step. So we have to make it and cover it first from below and make it like a more compact design. Next step is the culture, sir.
Any discoloration of the gadget?
No, sir, not found in short term, but sure a long term effect would be appreciated.
It's a good thing.
Good one.
Idea was very good.
Idea is good.
Good idea. I think it would have been very, very useful in COVID time.
Yeah.
But at present, I think it makes sense also. Thank you.
At least we can keep the sit lamps when we leave the theaters. It means our OPD time.
Yeah.
Optics.
Thank you. Thank you so much.
Thanks, sir.
The next presenter is Dr. Debashish Datta. Can a CTR be placed in case of posterior capsular rent? Can a CTR be placed in case of a posterior capsular rent? Here is a case of Brunison cataract where a large rhexis is attempted just beyond the mid-dilated pupillary margin. There is no epinucleus whatsoever. After a light hydrodissection, a bimanual rotation is attempted but in vain. Tremulousness was overt, and so capsular hooks were placed forthwith. Phaco was attempted with a balance tip with 2.8 millimeter sleeve through a 3 millimeter limbal incision. This was all done to avoid a wound burn. After removal of the nucleus, a central PCR was noted. Triamcinolone was used to stain up the anterior vitreous. A limbal vitrectomy is performed to remove the remnant cortex and the vitreous. After the central area is cleaned of remnant cortex and vitreous, a CTR injector is used in tandem with a bimanual approach. This ensures absolute control over the slow injection of CTR. The capsular equator is defined and the rhexis is centralized. Thus, the posterior limit of the sulcus is reinforced. After this, a multipurpose acrylic IOL is placed in the sulcus. So we have a ridge sulcus which is well supported by CTR from behind.
Thank you.
Anterior chamber is secured with a limbal suture. Thank you.
So when you were going to place anyway the IOL in the sulcus, what was the purpose of the CTR? And very risky if you had the CTR could displace posteriorly because you had a very large PCR.
Yes. Now, how do I know that my sulcus is intact? So anyway, even if I put it in the sulcus, the anterior capsule was not very well normally visible. And to make sure that
I have an intact, the equator. So I placed it in the equator of the bag, inside the bag. So the posterior limit of the posterior chamber is well defined and it is firm. Whatever I place in the sulcus is going to stay. So even if your sulcus is not there, if you put it in the sulcus, maybe one side will be there, one side may go down, and I may lose the lens into the vitreous. So if I am sure that my sulcus is absolutely reinforced from behind, the posterior limit of the posterior chamber is defined, I can place a sulcus lens with confidence.
Your CTR doesn't it enlarge the posterior rent?
It just centralized the anterior capsular axis. Posterior rent was too big.
Sir, because in the end, it slipped from your left hand.
It was, because if you inject a CTR with a PCR, it is not done. This is not in the books. It is, off the shelf. So, if you try it bimanually also, it is very difficult.
Okay, yeah.
So, it is absolutely controlled. I can direct first of all, my CTR which I am injecting is not going to rip the rest of the bag which is there. And the loop which is created in between with the left hand which I am holding, the eyelet, that I am carefully placing it just below the anterior axis margin.
That will produce a snap like this?
No, it will not. It is a controlled, bimanual, it is not, I'm just not letting it go. Neither my leading eyelet is going to pierce through the capsule or something like that. It is a non-edged circular middle portion of the CTR that is going to...
No, I'm not talking about that area, towards the end when you pushed it.
I just let the last eyelet go when the entire thing is almost in place.
So how many cases have you done of CTR in presence of PCR?
I don't think I've done many, but this was I thought I could share, that's why I brought it.
Hey, but tell me, your hands may be very expert, but if this message goes in the audience, that this is something we can do, I feel there'll be many more lying in the vitreous than actually lying inside the bag. One, and second thing is that you're putting a ring in sulcus, you're putting the haptics in sulcus. So what is happening to the sulcus and what is happening to anterior chamber angle?
Ring is inside the bag.
Are you making a PI regularly or not?
The ring is inside the bag.
See, ring is in the already bag, and then you're putting one thing in the sulcus. So you are narrowing the anterior chamber angle in any case.
It is in the posterior chamber, madam.
Sir, you have been very fortunate.
I'm talking of sulcus, right?
I must say. And this is probably not the technique which can be practiced and should be promoted to any person who has got a PC rent and trying to check let me speak and complete, sir, and to check the integrity of the sulcus. The better method, if I may suggest, better method is to take a suture in the posterior haptics and let the antihaptic go inside to see whether it goes into the sulcus and lens stays stable. And rotate the lens. If it stays, then you can cut the suture and leave it inside. If it doesn't, then you can pull the suture out and take the IOL out and do whatever you want as
Absolutely
SF
agreed,
or
sir.
AC IOL.
Absolutely agreed.
But to check with an expandable device like a CTR is not a fantastic idea. I would not suggest it to any of my fellows, and I will not suggest to any of the audience sitting here to try it and let the CTR sit on the macula and the lens again sitting on the macula later, 2 years or 1 year down the line. So that is my take, and I'm sorry for all the comment, but whatever you want to take it.
Sir, if well said, I agree with you, sir. But because what I wanted to stress, that it is not done. It is well known that it should not be done. You cannot put a CTR in a PCR. It is no question about that. But the bimanual technique gives you a different order of a control. That's what my point is. And as you said, I could have put in a loop, a suture in the leading loop and done it to have a control, bimanual control. That's the situation. So a CTR can be taken a risk. If you have a bimanual, injected bimanually, you have a better control in the bag. That's all. That is my point only.
So if it could just make a comment from the audience side. Sir, it is so disheartening to put a CTR in a PC which is opened up. Not the question of putting, how do you retrieve it? Imagine the Rexis extends, you are in a situation to retrieve it. How are you going to retrieve it? Unless you put a switcher.
I am in control of it. If I see that thing going wrong,
no sir, only after sitting,
I think we should
after
stop it
sitting
here.
the equator of the lens bag is expanding, then is the time you realize the Rexis, the rent is going to extend. At that stage, how are you going to retrieve? That is one question. That is why I came to the podium. Thank you.
All right. I think your point is well taken. Thank you. Thank you so much.
Thank you. Thank
you. So we move on to the next presentation by Dr. Rama Rajgopal. Dr. Rama Rajgopal is here. I don't see him here. It's a good technique. I think I'll show the video again. No marks for this, please. It's a cotton bud. So we move on to the next presentation by Dr. Sugato Paul. Dr. Sugato, please. Rescuing Rexis run out with Johnson bud when Brian Little's maneuver fails. So again a magic of bud. Yes. Dr. Mohan Rajan, you are listening, I think.
So many. Yes, but the bud not Brian Little technique is a very useful technique in retrieving Rexis run out. In this case, my Rexis has run out. I have gone with viscular stick to flatten the periphery where the Rexis has run out, and then with the Haldipurkar forceps, I will be putting the flap back and then a sharp pull in the center to retrieve the Rexis as described by Brian Little. But what if Brian Little's technique fails? I'll demonstrate a new technique if Brian Little's technique doesn't work. Here, the Rexis has run out. I have noticed that and stopped immediately, gone in and put viscular stick over the run out area in the periphery to flatten that area. Then with the Haldipurkar forceps, tried a sharp pull in the center, but it didn't work. It stays in the periphery and I couldn't pull it back. So I'll be demonstrating with the Johnson's bud how I could retrieve the Rexis. So with the Johnson's bud, I'm pressing just beyond the limbus to relax the zonus so that the pull on the anterior capsule is gone, and then very easily I could retrieve the Rexis back to complete the CCC. This is the technique I have demonstrated first time and wish you could utilize this technique in case of Rexis run out.
Very, very nice.
Thank you.
So it has gone beyond the limit because because we have not debulked the nucleus.
Yes. No,
so if we do it in the beginning, if we create a small axis and we debulk we aspirate some amount of cortical matter, then things becomes very easy. You can do it very easily. You can maneuver your optimum size of axis.
Sir, in this patient, actually I debulked. Normally I do rhexis in 3 steps in this situation. First I debulk by putting a needle and puncturing and pulling it out. Then I do a small rhexis and then debulk the periphery. But overconfidence sometimes is bad. Even after I debulked the central one, I didn't do a small rhexis. I tried to do a large rhexis in the first go and it was going out and I couldn't pull it back. So what Johnson's bird does, it actually takes away the centrifugal force of the zonules. It's like I'm creating a zonulopathy. So by pressing on the zonules, it takes away the centrifugal force of the zonules on the capsule, and then it's easy to pull it back. But yes, I should have debulked a bit more, so I couldn't have done, it couldn't have gone out. But in that situation, I couldn't have presented this in the auspicious.
Yes, but it's a good suggestion, sir. We can try this also.
Sir, you have actually captured the pathology of runaway rhexis very beautifully.
Thank you.
Because you have relaxed the zonules.
Yes.
Yes.
But my take is that sometimes zonules will still continue to, pull the rhexis out because it's a matter of zonules if you are not able to remove all of them. So what I suggest in all these cases is take a 26 gauge needle and swipe it between the lens capsule and iris with the needle tip all along the rhexis going beyond the area where the tear is. And you have removed all the zonules from there, and then without doing much, just keep the viscoelastic sufficiently, not over, neither over nor underinflated, and just pull the rhexis. Once you have cut the zonules, you will never lose the rhexis again. So the best thing is, as soon as you find, try to focus the microscope at a higher magnification as to see where, up to what extent the zonules are coming on the antecapsule. See, in some eyes, the zonules are coming up to 5 millimeter. In some, you will find that they are not there up to anything up to 8 millimeter. So you have to find where the zonules are. Once you have focused in, a higher magnification, then you will know where the rhexis will go if you reach that point. So you have to, incise and cut the zonules from there.
Yeah.
But you have captured the pathology. This is the pathology,
yes.
And you have relaxed the zonules. That is, taken care of the runaway rhexis beautifully. Thank you.
Thank you, sir.
It's a good tip. It can be utilized of rhexis runaway.
Yeah, sir, can we use other than the bud anything else?
Yes. You can use MacPhus, any instrument you can use to depress the thing like in retinal detachment surgery, you can use those pressure, depressor, but that is available on the table at that time on emergency, and it's not near the wound, and the easiest way to use it.
Excellent point, sir. Just one thing, you're pressing it, and at the same time, we are trying to pull it.
Because
so the pressure has to be very controlled.
Yes, it is.
So, how much you press,
yes.
It's only by trial and error you will know, number one.
Yes.
Number two, when you're pressing, the pathology is increased intralenticular pressure. So when you're pressing it, if there is any loss of viscoelastic from the side port or from the port from which you're removing, then it can, shallower the anterior chamber and it can really run out.
But with experienced hand, I think it's very easy to manage just little bit of pressure to relax the zonule, and you can see the video, it becomes so easy to pull it back. It becomes
so
very
probably
easy.
we need to really
Very
optimally
pressure,
fill the anterior chamber
Yes.
and start with a little pressure. So that probably has a short learning curve. How much pressure to put so that you can bring it to the center. Thank you, sir.
Thank you.
Thank you. Thank you very much. So we move on to the next presentation by Dr. Kanwaljit Harjot Madan. She's going to present management of refractive macular hole. So what is the tip you want to share here?
If there are patients of refractory macular hole, we should not leave them. We should try to do surgery. It will help in better anatomical and functional closure. Better visual results would be there.
Ma'am, I'm not a retina guy. Basically, I'm refractive and cataract surgeon, but still, I know this technique. I think it's a majority of surgeons, VR surgeons, they are doing it for the last so many years. So, anything and any suggestion further to that?
Ma'am, any particular size of macular hole you prefer this, or is it in all cases? Any criteria you have? Macular hole
they
size?
were just referred cases of a refractory macular hole. The holes they didn't close after the first surgery. So size we didn't take into account.
Would it stay there? Wouldn't it move away?
Can I say something? If you want me to add. I think your hole already had an ILM. ILM was, you had stained with ICG. So ILM was there.
In the first case, sir, there was residual ILM, so we used that flap only. And in the second case, when we stained the ILM, it was not there. So we thought of using fibrin glue.
Right, yeah, fibrin glue has been shown, but if it doesn't work, you can take ILM from anywhere in the retina and just slide it and put it there. Or you could even take the graft which they do, amniotic membrane graft, and that can also work.
There have been studies of using amniotic grafts and even capsular flaps of the lens also. But we thought of using fibrin glue because there have been study of by Dr. Mudit Tyagi. They are using fibrin glue for retinal detachment surgeries.
Correct.
Thank you. Thank you very much. And we have now the next presenter is Dr. Shweta Singh. She is going to present 36G needle to prevent hypotony. So the magic of 36G needle.
Vitreoretinal intervention involves maintaining intraocular pressure throughout the surgery. For that reason, the infusion cannula is always the first in and last out. After removing the infusion cannula, there is a risk of hypotony-associated bleeding that occurs especially in predisposed cases, like diabetic vitrectomy. Here we have devised the use of 30-gauge needle to prevent hypotony in selected cases. At the conclusion of surgery, we first clamp the infusion tube with the artery forceps. Thereafter, disconnect the air pump from the infusion tube. This air pump from the vitrectomy machine is then connected to the 30 gauge needle, and the globe is inflated to reach the desired intraocular pressure. After that, we remove this clamped infusion cannula. Meanwhile, the globe is insufflated by the air pump connected to this 30 gauge needle. This infusion port can now be closed by 7/0 nylon suture. After closing all the ports, this 30 gauge needle can now be disconnected. Because the port size of the 30 gauge needle is very small, around 0.159 millimeters, it is unlikely that its removal will cause hypotony, and mild pressure by the soft tip is sufficient.
So any questions?
None of us are literate.
No, but you're connecting it to an air pump. So is the air sterile? Are you injecting air at the end of your surgery?
No, ma'am, we are not injecting air. The air from the infusion from the vitrectomy machine. Basically, we have the infusion pump from the vitrectomy machine and the cannula. So we clamp the cannula and then disconnect this cannula from the vitrectomy machine pump. Meanwhile, we connect the 30 gauge needle to the vitrectomy machine pump. And then we are inserting that 30 gauge needle from the pars plana site inside the globe. And the globe pressure is maintained by that vitrectomy machine pump only. So that pressure we can maintain with our setting, whatever we like.
No, but what is maintaining the pressure? There has to be something injected inside. Is it air or is it saline going through the needle?
Ma'am, air. It depends whether we
air
want...
is going. So that's what I said. That means at the end you're leaving air inside.
Yes, ma'am. That is a usual procedure. Sometimes we have to leave the globe under air, and that air comes from the vitrectomy machine.
So usually if you would have removed it from the irrigation, it would have leaked out. Here you're preventing that leak.
Yes,
so it's
ma'am.
very, very nice.
Yes, ma'am. It's just because it is a 30 gauge needle, we need not suture it.
And probably if it's at an angle, even lesser chances of
Yes, ma'am.
Very, very smart.
It's giving a safety handle actually.
Yes, ma'am.
It's the same FG pump that you're using for otherwise FG, same thing.
Yes, ma'am, same.
Can I just add a note here? We are using valve cannulas now, so when you are coming out with the valve cannulas, you anyway don't decompress. This is particularly useful when you are not using a valve cannula. So when you are not using a valve cannula, you have to tie a suture. When you're using a valve cannula, you don't have. And one tip for you,
Yes.
when you go through a needle, don't go perpendicularly.
Yes,
go
yes,
in
yes.
an angled
No,
manner, it will not leak. Even a 30 gauge can leak.
Thank you, sir. No.
So our next presenter is Dr. Ajay Arora. He's going to present a novel device for subretinal injections. Dr. Ajay.
Hi, I'm presenting a novel system for injection into the subretinal space. The interest in subretinal injections has increased because gene therapy, cell therapy and drugs can be injected in the subretinal space using subretinal cannulas of 38 to 41 gauge. This can be done by the surgeon by pushing the plunger or by assistant pushing the plunger or using a VFI system as has been developed by Medone. I'm presenting this novel system in a case of a massive subretinal hemorrhage, and I'll demonstrate the utility of this system. So there is an adapter to which is connected a tuberculin syringe and a 10cc syringe. You can see the adapter here. The tuberculin syringe, which has been loaded with TPA, is put into and fixed with the adapter. Now the 10cc syringe, which is connected on one side to the vitrectomy system, to the VFI, is connected and loaded onto the adapter. Here the bush of the 10cc syringe will push the plunger of the tuberculin syringe, which will drive the drug into the eye. The system is primed. You can see the system being primed. The air is removed. You can see the TPA which has come to the tip. We enter the eye, and as I go inside the eye, you can see that there is a change in the reflex the moment I enter into the subretinal space. You can see the change of reflex now, and then the drug is injected. Same step is taken at another site and the drug is injected. This is the post-injection picture where the subretinal heme has been removed and the patient's visual acuity is improved. So the Med1 device is expensive, it's a single-use device, disposable, generates a lot of plastic, while this novel device is cheap, does not generate a lot of waste, and is autoclavable. We have now 3D printed the device, and it's autoclavable softer material, and it is very useful for subretinal injections. Thank you.
How much learning curve does it require? What is the level of expertise required for this procedure?
Sorry?
Level of expertise required to do this?
Level of?
Expertise.
Ma'am, for anybody who is going to inject a drug or aspirate from the subretinal space has to use a tuberculin syringe and either inject or aspirate. Now here, there is no expertise required. You go into the subretinal space, put a foot switch so there is no handshake. Because there is no handshake, there is no enlargement of the retinal opening. And when we are using a 41 gauge cannula, we don't even laser this opening. So this will be particularly useful for gene therapy. If you're going to inject genes below the retina, it will be particularly useful for taking samples, especially in cases of ocular lymphomas, where you want to take a sample from the subretinal space. So till now, people used to take a tuberculin syringe, connect a 41 gauge needle and aspirate. So when I aspirate, my hands will shake, I will enlarge the opening, and if you are injecting the gene, you will be injecting it into vitreous cavity when it has to go to the subretinal space. With this, you can inject it inside. So I wanted to highlight, this is a metallic device, or now we have made a softer material. We use a tuberculin syringe. The Med1 device, which is now becoming available in India, it's a single-use, large plastic, lot of plastic waste. This hardly has any plastic waste. Both use 41 gauge needle, which we have to get anyway, and otherwise it brings down the cost dramatically.
Great. Very nice.
Nice concept.
Thank you. And the next presenter is Dr. Shweta Singh again. Basically, we got 86 entries for this 2 Mins to win, and the evaluator had selected the first 14 that you're going to see.
Every vitreoretinal surgery is different, and we face new challenges in every case. Toughest are the sticky membranes, which are very difficult to remove, especially seen in cases of high myopia and diabetic vitrectomies. Some of these membranes are just well left behind, because over-enthusiasm can be dangerous. Very similar to our master blaster getting bowled on a wide ball. Ways to manage these sticky membranes include applying silicone band to support the vitreous base, one can also do PFCL dissection of the membranes. And finish off the case with sufficient laser to ensure retinal adhesion. Despite doing all these measures, some membranes are better left behind. So next time when you are managing these sticky membranes, use PFCL to create the dissection plane, but also take care when to leave these membranes behind to prevent creating any hydrogenic break. One must learn from Master Blaster that sometimes to win, whether it is cricket or achieving surgical success, some things are just well left.
So you mean do no harm at least?
Yes, sir. Especially in cases of myopia, high myopes who have in which we have to treat the retinal detachment. There's chytic vitreous and the membranes are very sticky. It is very difficult to induce posterior vitreous detachment, and sometimes even if we induce detachment, it does not goes beyond a little bit beyond arcade. In that cases, 3 tips: we can apply band. We need not be very aggressive with removing the membranes. use PFCL, which provides us the plane, and then if some vitreous is leaving behind, we can just laser it off. So that's the 3 tips.
Not to do something is also to do something.
Yes.
Yes.
That's why the title well left.
So
it's normally done like this only, belt buckle in these situations. You always put a belt buckle and you do this. So like, is there anything novel or new about this?
Nothing.
So it's not necessary always to be a hero.
Yes.
Once it's okay, it's okay. Thank you. Thank you so much. And we have Dr. Atul Espalat here. Dr. Atul, he was the winner last year, so we wanted to give him an award. Dr. Atul is not here. Right, so we'll come to the end of this thing, and meanwhile the judges are taking time to just finalize the list. Take care of your eyes.
But Dr. Vinod, we want to know your tip for the year.
Arrange meeting like this. No, it's yeah, please. Okay. Before we celebrate, we have got with us Dr. Neha Dholakia. He was the honorable judge, but came a little late, and he's got a good innovation. I think we can see that one also.
2 minutes to win it. How often have you introduced a lens just to see the haptic optic being cut? And the only way to remove this is either extend the incision, the twist and out technique, or using traumatic scissors to remove the IOL. This can cause SK and even Desmond's detachment. Introducing these new ultrasonic scissors, which basically cuts the IOL into 3 or 4 parts and can be removed through a 2mm incision without inducing any astigmatism. It has to be just attached to the phaco tip, just press the foot pedal and you're done. Now the temperature is the same as phaco, so it doesn't heat more, and the power is 30, vacuum is 0, aspiration 0, irrigation is on. This is how a plastic piece could be cut if it was used mechanically by mechanical cutting, and here is with an ultrasonic blade. This attaches with every phaco machine. This is an example of a case where there was pitting of the IOL and the lens had to be explanted. This is done by Dr. Santosh Bulchandani in Bombay. Patient did not want any glasses, did not want any astigmatism, wanted to go to Dubai and drive. Plano 66, crystal clear cornea, no SK. The second case done by Dr. Kamal Kapoor, 32 diopter IOL, very shallow AC, and he just slices the opacified IOL like butter. This has to be used for removing opacified IOLs, dislocated IOLs, halos and glare. Patients can't tolerate post-refractive surprises and any cut IOL at the time of implantation. Just like a vitrectomy cutter, it can be kept as a standby and is available on www.iolcutter.in. If you see, it's cutting very nicely, keeping the sleeve intact. You can ETO it and keep it aside. The other use of this cutter is to cut very hard cataracts. As you can see with the horizontal chop, instead of using a manual chopper, you can just cut the hard cataract into 8 pieces, just like a femto. Thank you very much.
Dr. Neha, please, you can come here. So no marks for that. It was a non-competitive one. It's available commercially?
Yes, it's available if you just go to the website www.iolcutter.in. There is a Google form which you have to fill, and that is which machine you have, the delivery address, and there is a barcode to scan. It's available for 13,500. That is a titanium tip with the lens holding forceps both.
Ma'am, any conference discount?
It's very close to the making price, honestly.
So one piece for every judge.
Okay, chalo.
Done?
Done.
Yes. It can be used with any machine?
Yes, sir.
Is there anything like disposable or consumable is there?
No, there is no disposable with this one tip. I have cut with one particular tip almost 30-40 lenses, and it's very sharp. If at all it becomes blunt. Where 30-40 lenses to explant is a long time. And the only thing is that the tip is different for every machine. Like an Earthly machine tip, you should not use with a Signature Pro. So the Johnson machine tips are similar, Alcon similar, Nidex similar, like that. And also, if somebody is using it, a practical tip, you go halfway to the center of the IOL. That's when you push the right hand forward, and with the left hand, after halfway, you pull the lens backward. So you try to stay in the middle of the eye. But every 2-3 days, I get a message, and I feel it's so heartwarming that I did a case. It was excellent. Dr. Ashish Vaidya called me last week, and he said it's very, very nice. The patient was so happy next day. Dr. Samresh presented a case at the conference, and luckily it's working very well. I think people are much, much better surgeons than I am, and they're doing a better job than what I would have done, honestly.
So it's the ultrasound which is cutting?
Yeah, so it's using the ultrasonic power of the phaco probe, and your hand is steady, your foot pedal you press, just how the phaco cuts into the cataract. This has a V shape, the scissors don't open and close, it just slices through the IOL. And even a hard IOL, like a opacified IOL, which are a little harder sometimes, hydrophobic IOLs also, which are harder than hydrophilic, it cuts through them very, very easily. In fact, it's very fast. So don't keep torsional energy on, just keep it longitudinal. Don't keep linear, keep it fixed, and it'll take a second to cut it.
I had a question, ma'am. I tried, we recently had cases where we wanted to use it.
Right.
And I could not get this thing. So what I did was I had a lens and tried to cut it with the phaco probe.
Correct.
It didn't work.
It will not work.
Why? That's why I'm asking.
Because
is it the scissor which is doing it?
No. I get it. So there is no scissor which is opening and closing. But the first time I tried it in vitro, I did exactly what you did. I thought it will just engulf it. But that's an inorganic material. Your cataract is organic. So it'll just create a little dent and come back.
That's what it
That's what it'll do. So then I had made a screwdriver type of tip, which I used the lens and I cut it like this, like a stamp. And then finally I got the idea, no, I will need a sharp edge. So it's that inner sharp edge which supports the lens from up and down and then moves forward.
There's no movement of the blade.
There is no movement of the scissors. And that's the best part, because if you open and close a scissor, it can cut the endothelium every time you're maneuvering and give rise to corneal edema, Descemet's detachment, etc.
But the blades have to hold the lens firmly.
No, so the blades don't hold the lens. Therefore, special forceps, which are called IOL holding forceps, are given with this purposely. They go through the side port. The jaws of the forceps open and close like a crocodile, but your grip is not vertical, it's horizontal. So it's easy and ergonomically better. These jaws hold and grasp the forceps very firmly. Therefore, first I had made the forceps in titanium, but titanium ones will break. So the forceps are made of stainless steel. So they grasp it, they are serrated edges, and then you get a good hold of the IOL and just move it forward.
Now the forceps are like the ICL forceps. Like the ICL.
No, so I would say do not use the ICL forceps, do not use the B-hex ring, do not use any vitrectomy. This is not so that you buy my forceps, but they'll break and you'll damage your forceps. That's why no titanium. Steel ones also, it should have a broad grip. So these have been designed such that it's a little like this and like a, I don't know, squarish tip so that it grasps the IOL well. It may have a little learning curve for the first time, so the next time it becomes better. But phaco tip, as you said, it will not cut it. I've tried that. So. It's the ultrasonic power which is making the tip vibrate at 60,000 hertz or whatever, and then your mechanical pressure also with the sharp edge and the counter pressure, all these three things working at one time is allowing it to cut.
It's mouth wide open. It's going actually inside that, so it works like that.
Yes.
So, one more question, sir.
Yes, sir.
So, ma'am, for using it with Alcon, say Alcon Infinity machine, we shouldn't be using the torsional phaco, we should be using only longitude.
Yes.
And one thing I was wondering, like the tip is quite pointed, but that has no function.
No, it has no function. So
if you can make a
it
bulb.
is, it has been made rounded.
Yeah.
Actually, my original design was rounded. Then I gave it to Epsilon, I mean, the other brother, Ushma. So he made the first batch according to my plan. Then the second batch, he made it sharp. I said, why? Just stick to the design. Absolutely, absolutely, Kat, because there's no use of that.
Thank you.
Thank you, sir.
So who's marketing it now, Epsilon?
No. So Epsilon has a partner. There are two brothers, Sanjay Anand and the other one, Shyam Anand. So Sanjay Anand has a company called Ushma. He's selling it. Because otherwise Epsilon and some of the companies just take away your ideas and do whatever they want with it. So, and it's patented now in Australia, UK, US and India. Rest we have applied.
So any discount who orders today?
Sorry, sir?
Any discount to audience who orders today?
Okay, we'll see. Hardly any discount scope left. Okay.
Thank you so much.
Thank you, Dr. Vinod, sir. Bye.
It's a wonderful innovation and makes the life very easy for all of us. With this, we come to the end of our session. And as customary, the award of this will be announced in the next conference. I would say they'll be intimated to them, and awards will be given in the next conference. This award is for the last conference. Dr. Ashok Sharma and Dr. Atul Putulat has won. But Dr. Ashok Sharma has received, Dr. Atul has not come. So maybe we can give him other time. Thank you very much. See you in Jaipur.
Thank you.
Thank you to all the honorable judges. Thank you so much. Yeah, please, all the presenters can come on the dais and have a group photograph if possible.